Good evening, everybody. This is our second CME from Dr. Das Hospital. And it is a great privilege and a pleasure to have someone who's so close to us to be with us in this CME. We welcome you for this CME. We are a non-COVID hospital functioning for the last nearly 14 months, 24/7 since the lockdown, which was imposed on us on 15th of March, 2020. We are located at Chembur. All our facilities are functioning. We have the OTs going on, the ICCU admissions with the isolation ICCU, which we have built especially for this. Our OTs have got smoke evacuation system. We have AHUs which are functioning overtime now at 40 cycles in an hour. The kidney dialysis is going on with Apex Kidney Care looking after it. And of course, our lab is 24/7 on. COVID RT-PCR test is being done every day with the help of SRV, SRL laboratories. And at 10 a.m., this is for OPD and for IPD patients. We are a registered vaccination center, but subject to availability of vaccines, of course. So when we have people coming in and without with us, we register the name and then we call them whenever required. For more about our hospital, you can go to www.dashospital.com. I have never seen Vijay like this. This is a photograph which I wondered must have been photoshopped, because Vijay and this photograph somehow don't match. He has always been a person smiling, never a person in so much of anguish. Vijay is a honorary consultant in Lilavati. He has his own clinic at Bandra East and at Dadar. He was ex-professor of KJ Somaya Medical College. And he has been holding multiple posts of different organizations in the field of diabetic management and endocrinology. But above all, Vijay has been a friend and guide to me. You know, when I came to Chembur in 1983 to start practice, it was very interesting that although I was in Chembur from 1958, I knew nobody in me cases. Forget patients, no doctor knew me. So I went to Vijay and asked him in a very tearful manner, "Kaise karne ka?" So he said, "Bindas chalu kar." He gave me a list and said, "Ye log sab logo mil." So I started meeting people. The first case I got was from Dr. Vijay Panikar. He wrote Dr. Debashish Das, pile specialist. And then when I saw the patient, I asked him, pile specialist क्यों लिखा? बोला, अरे, he didn't say अरे, he said, अरे गधे, अगर तू surgeon लिखेगा कौन आएगा? Pile specialist लिखा तो आएगा. So above all, Vijay has been a very good friend, an excellent diabetologist, and in his field of endocrinology, he's been an expert. Without much more, I would like to hand you over to Dr. Vijay Panikar to speak to us about today's talk, that is aggressive management of diabetes mellitus type 2. Sorry, I'm just having a little difficulty here. I'll get through.
Thank you, Debashish.
Okay. Over to Vijay.
Introduction. You know, I have very nostalgic memories of Chembur. I practiced there for exactly 1 year and 6 months. And then I didn't have the time. So I had to move out. But as mentioning about this pile specialist, that patient had piles. That is why I send him to you as a pile.
Thank you. You're not heard.
Specialist.
Yeah.
You hear me?
Yeah, you can hear you.
Are my slides visible?
Yes, yes, it is.
All right. So without much ado, I will come straight to the topic. Das has suggested aggressive management of type 2 diabetes in 2020. Am I audible, Devashish?
Yes, you are. You are. You are
Good.
audible.
And my slides are visible.
Yes, it is.
Good. And this aggressive management of type 2 diabetes in 2021 should be evidence based. It is not Panikar's opinion or XYZ's opinion. Now, the first question is, why should we aggressively manage type 2 diabetes? See, today, diabetes has become an epidemic, and especially in our country, diabetes starts 10 years earlier than the Caucasians or the whites. And we see younger and younger diabetes in their 20s. We are seeing the patients there, and the complications are much more and much earlier in our diabetic patients. Look at this. What is the cost of life? If you have a non-diabetic at the age of 30, you can live up to the age of 75 as of the statistics today. But if you have a diabetic patient who becomes diabetic at the age of 30, he stands to lose 14.5 years of his life. That is humongous. So when we are treating a type 2 diabetes, this is what should be in our mind. Let us not be just glucose modulators. We should be looking at the patient holistically and seeing that how can you give him a full, healthy, long life and knock off that 14.5 years which is standing to lose being a diabetic. Now, at the onset of diabetes, this was the UKPDS study where they were newly diagnosed type 2 diabetes. At the initial diagnosis, 50% of the patients presenting with diabetes already have some complications or the other. So we have no time to. What is most important is 80% of type 2 diabetics will ultimately die of a macrovascular disease. And what is that macrovascular disease? It is a coronary artery disease, a cerebrovascular disease, or a peripheral vascular disease. So 80% are going to die of that. End stage renal disease is the bane of type 2 diabetes. You go to any dialysis unit and you will find 60% of the patients are type 2 diabetics with renal failure. And now there is a new epidemic on the block, and that is your non alcoholic fatty liver disease. It is extensive. We are just seeing the tip of the iceberg. And this non alcoholic fatty liver disease can progress to cirrhosis and to hepatocellular carcinoma. And it has become the number one cause of liver transplant in the US today. And Indians are an insulin resistant population. And the incidence of NASH and NAFLD are very high in Asian Indians. The UKPDS was a major study that was done in newly diagnosed type 2 diabetics. And what they showed was that a good glycemic control early in diabetes has lasting benefits, including on cardiovascular risk. And what they showed in that study was that getting the HbA1c to below 7, glycosylated hemoglobin to below 7, was the gold standard. And what followed was every guidelines started saying HbA1c below 7. This is the 2006 ADA and the European Association of Study of Diabetes guidelines, which says diagnosis, lifestyle intervention, metformin. If HbA1c is more than 7, treat. If it is less than 7, don't treat. So everywhere it was HbA1c 7. Then some people started thinking that maybe if we could get HbA1c to below 7, say 6.5, you could have much better results. And they looked at these major real life studies, ACCORD, ADVANCE, and VADT. These were all patients who were diabetics and they had comorbid conditions, especially cardiovascular diseases, and they went in for a tight glycemic control. And what did they really find? That there was absolutely no benefit of this intensive control on cardiovascular mortality and all-cause mortality. The nephropathy did improve. The ACCORD study was discontinued because of excess mortality. So what we really got the message out of this was That big message for cardiovascular disease is that you can have a good glycemic control, but that does not prevent heart attack. And you can die of a heart attack even with a HbA1c of 6.5. So basically, yeah, basically, a good glycemic control is not enough to protect your patient. Now let us look at the treatment of diabetes. The therapeutic class of hypoglycemic agents currently available, there are 8 drugs. 6 are oral, 2 are injectable. This is Ralph DiFranzo's ominous octet, extensive study which he has done and presented beautifully that these are the 8 different pathophysiological mechanisms which lead to hyperglycemia. You have decreased insulin secretion, you have increased hepatic glucose output, you have increased glucagon from the islet cells, which contributes to hyperglycemia, you have decreased peripheral uptake, increased glucose uptake from the kidney, increased lipolysis, which leads to lipotoxicity, and a decreased incretin effect. These are the ominous octet. Now, when you look at this, when you look at the ominous octet, that there are 8 different mechanisms, and now we have the dirty dozen. There are 4 more which have been added. No single drug in the world can absolutely control all these abnormalities. So if you have to treat your patient, you have to treat holistically. So treating type 2 diabetes with a single drug at a time is a treatment strategy which is doomed to failure. Absolutely doomed. You need combination therapy right from the word go. And given this finding, why not hit hard from the start, using several drugs together to nullify many of the known defects of type 2 diabetes and prevent beta cell dysfunction early, preserve the beta cell function. So when you're treating type 2 diabetes, there are 2 basic aspects. One is a good glycemic control. Now, glycemic control is going to manage your microvascular complication. It prevents your nephropathy, your retinopathy, and your neuropathy. But the overall, it is not just glycemic control. You have to address the dysmetabolic syndrome, which is insulin resistance, obesity, hyperinsulinemia, hypertension, dyslipidemia, atherosclerosis, and procoagulant state. So when you look at combination of drug therapy, what are the physiological targets that you want to treat? You want to achieve good glycemic control. You want to preserve the beta cells so that it will give a good, durable glycemic control because the beta cells keep dying. You need to treat insulin resistance. And at the same time, you should not cause hypoglycemia or weight gain. And preferably, if you get weight loss, that would be an added benefit. It should be renoprotective because most of the patients ultimately go into renal failure. And it should have cardiovascular benefits. So these are the plus points that you look for when you're trying to treat a patient with type 2 diabetes. So let us look at achieving good glycemic control. Every anti-diabetic drug has a HbA1c lowering efficacy. Among them, the most potent are the insulin and the sulfonylurea. So any of the drugs can be used. All drugs will reduce and achieve good glycemic control either alone or in combination depending on the state of the patient. Now you want to preserve beta cells which give you a durable glycemic control. Progression of type 2 diabetes is dependent on the beta cell. As the beta cell will go on dying, you will have less and less insulin in the body and the sugars will go up. This is a classic slide from the UKPDS that at the time of diagnosis, you see 50% of beta cells are already gone. And over a period, there is a steady decline and apoptosis of the beta cell. This is what leads to the progression of the disease. This is the natural progression of the disease. If we can prevent this natural progression, you can maintain the patient very well. Now, these are 10 studies which used sulfonylureas. You have glimepiride, glyclazide, glyburide, all these, glipizide. Initially, you see the HbA1c comes down very nicely for the first 1 year. Then you see a gradual increase in HbA1c over the years. What is this telling us? That the disease has progressed. Why has the disease progressed? Because there has been a progressive beta cell apoptosis, death of the beta cell. So insulin levels come down and the sugars go up. These are 8 studies which uses a glitazone. As of today, the only glitazone available is pioglitazone. If you see, initially there is a good decline in HbA1c, but it is maintained for longer periods of time. What does this tell us? That somehow these molecules have been preserving the beta cells. That is the most important thing. Now, why does the beta cell die? There could be a genetic background. We don't know what can be done about it. But lipotoxic and can kill the beta cell. But lipotoxicity, elevated free fatty acids, triglycerides, these get into that beta cell, and that is what causes the apoptosis. So lipotoxicity is a very important aspect in beta cell apoptosis, and insulin resistance by itself and by activating lipolysis and hyperglycemia can lead to apoptosis of beta cells. So a glitazone, that is a pioglitazone, has a direct effect on beta cell, amelioration of insulin resistance, reduction of free fatty acid, that is reduces lipotoxicity. But most important, what you see in yellow here, mobilization of toxic lipid metabolites out of the beta cell. That means it reduces that lipotoxicity. There is a reversal of glucotoxicity, improves the pro-insulin insulin ratio, and decreases the prevalence and severity of amyloid deposition in the beta cell. And these are the mechanisms by which a glitazone preserves the beta cell. Preserves means it prevents the apoptosis or to a great extent delays or slows down the process of apoptosis, giving you a very durable long-term glycemic control. So when it comes to good glycemic control, all molecules, for beta cell preservation, you have only pioglitazone. You need to treat insulin resistance. 83% of type 2 diabetics are insulin resistant. And insulin resistance promotes atherosclerosis even before it produces diabetes. There are 2 large prospective studies, the Helsinki policeman study, Verona diabetes complication study, which have demonstrated that insulin resistance is a very strong, independent predictor of cardiovascular disease, myocardial infarction, and stroke. This is the famous ticking clause hypothesis or the nurses' health study, wherein over a lakh of nurses aged 30 to 50 years were followed up for 20 years. And what were they looking for? Relative risk of myocardial infarction and stroke. Those of these 1 lakh nurses who had no diabetes and who never became diabetes, the risk is considered as 1. But those who had diabetes right at the beginning have a 5 times greater risk of developing myocardial infarction and stroke. Those who became diabetic during this 20-year period had a 3.7% increase. And those who became a diabetic after developing myocardial infarction or stroke, that is a 2.8 times increased risk. So, what is the real outcome of this study? Take home message. Cardiovascular risk begins at least 15 years before the diagnosis of diabetes. So there is no hyperglycemia, there is nothing, there is something else which is working there. This risk started 15 years before the diagnosis of diabetes. So insulin resistance is highest in the Asian population, and this is seen in n number of studies. These are so many other studies which show that insulin resistance has been demonstrated in Indians even during adolescence. Now, what are the clinical manifestation of insulin resistance? There is glucotoxicity, lipotoxicity, which causes increased free fatty acid, decreased adiponectin, which is a good cytokine. What does this ultimately lead to? Diabetes, hypertension, atherosclerotic cardiovascular disease, heart failure, sleep apnea, peripheral vascular disease, stroke, PCOS, and non-alcoholic fatty liver disease. So insulin resistance is a gamut of symptoms, and it affects every nook and corner of the body. and that has to be treated adequately. So the next question is there any evidence that if you treat insulin resistance, it will help? Let us see. What are the treatment options for insulin resistance? Non-pharmacological treatment is diet, exercise, and weight reduction. Anybody who has a weight reduction and who is exercising will have a reduction in insulin resistance, no question about it. In the pharmacological treatment, you have metformin and pioglitazone, but predominantly pioglitazone. Metformin only reduces the hepatic glucose output. Now, there are these diabetes prevention trials where they have looked at patients who are pre-diabetic or with impaired glucose tolerance, given them lifestyle modification, exercise, diet, and showed a very good outcome in preventing the onset of type 2 diabetes. Now, pharmacological intervention, there has been with metformin, but with all the glitazone, the troglitazone, the pioglitazone, rosiglitazone, and again act now pioglitazone, and iris study which has recently come about, which I will stop. And what were all these studies doing? They were just treating insulin resistance and had an excellent results. This is a study which is beautiful. This is a study which was done in non-diabetic patients who had a transient ischemic attack or an ischemic stroke. Now these patients, they tested for HOMA. If HOMA was more than 3, you calculate the fasting sugar and the insulin, and there is a formula to calculate the HOMA. And if it is more than 3, it is considered insulin resistance. So those patients who had a TIA or a stroke and who had insulin resistance were treated with pioglitazone 15 to 45 milligrams for 5 years. And there was a placebo group, comparative group. And the number was 3,895 patients. And what were the outcome they were looking for? Fatal and non-fatal MI, fatal and non-fatal stroke. And what did they find after 5 years? Recurrent stroke was reduced by 24%. Myocardial infarction was reduced by 24%. And new onset of diabetes, mind you, these are all non-diabetics. New onset of diabetes reduced by 52%. Phenomenal results. And this is the first time that they have shown that a therapy directed exactly treating only insulin resistance has shown to prevent cardiovascular and cerebrovascular events, suggesting that the glitazone or the pioglitazone has an anti-atherogenic and an anti-atherosclerotic effect. Now, in the same study, they look at a subset and they tried to see whether pioglitazone could reduce cardiovascular events in pre-diabetic patients who are not full-blown diabetic, who had maybe an impaired glucose tolerance or impaired fasting glucose or a slightly higher elevated HbA1c, but not in the diabetic range. And in this post hoc analysis, they found 2,885 individuals. And what did they find in that analysis? That stroke and myocardial infarction reduced by 40%, stroke by 33%, acute coronary syndrome by 52%, and new onset of diabetes by 48%, and all this in a median follow-up of just about less than 5 years. These are phenomenal results, suggesting that treating insulin resistance is a very important aspect in treating type 2 diabetes if you want to prevent macrovascular complications. Of course, there are contraindications to the use of this drug, about which we will talk later. Now, metabolically active molecules which are linked are the atherogenic cytokines, your CRP, interleukin 6, PAI, TNF-alpha, etc. All these are the atherogenic adipocytokines, and unfortunately, in type 2 diabetes, these atherogenic adipocytokines are grossly increased. You have an anti-atherogenic adipocytokine, which is adiponectin, which unfortunately is reduced in type 2 diabetes. So type 2 diabetes is a very pro-atherogenic milieu, and it is what causes premature atherosclerosis, and that is why you have younger and younger patients who come with macrovascular disease. So when you do a PPAR gamma activation, that is use of pioglitazone, there is a direct and indirect benefit. cytokines, chemokines, and indirect through all this, and that blunts atherosclerosis. And there are n number of studies. I will not go into the detail for constraints of time. You have the Periscope study, the Chicago study, the proactive study, which has shown the benefits and even showing the reversal of atheromas in the arteries. So when it comes to treating insulin resistance, you have bio and metformin. So that's the best combination that you can have today. Should not cause hypoglycemia. Yes. See, if hypoglycemia was not there, there would be no need for a diabetic specialist or an endocrinologist to treat diabetes. You could just give any number of drugs, any dose, and go to sleep. No problem. Remember, as far as hypoglycemia is concerned, there are only two drugs which will cause hypoglycemia: the sulfonylurea and the insulin. All the others, the chances of hypoglycemia are very rare, though theoretically they can cause, but not the way a sulfonylurea or insulin can cause. So if you don't use a sulfonylurea and insulin, the chances of hypoglycemia are gone. So when it comes to hypoglycemia, all drugs except sulfonylurea and insulin can be used. In elderly patients where you don't want hypoglycemia, you should not use these drugs. In patients who have known severe cardiovascular problems where hypoglycemia can be detrimental to their outcome, do not use these drugs as far as possible. Now, should not cause weight gain and should preferably promote weight loss. There are three drugs in this entire group which can cause weight gain. And the three drugs are sulfonylurea, your glitazone, and insulin. If you don't use these three drugs, there will be no weight gain. But remember one thing. Now, when you talk of weight loss, SGLT2 inhibitor cause a weight loss of 2 to 3 kilos. This is our study published sometime back on use of SGLT2 as a fifth drug. We showed a 3.03 kg weight loss in a matter of 6 months. This is liraglutide, which shows a weight loss of 2.3 kg in 3 years. Pioglitazone causes weight gain, but lowering of visceral and hepatic fat. Look at this. These are the MRI studies. Look at here. Before pioglitazone and after pioglitazone for 16 weeks. Subcutaneous fat is 144. It increases to 204. So when you give pioglitazone, the subcutaneous fat increases. And that is what leads to weight gain. But look at the visceral fat. It is 140 and 105. There is a 25% reduction in visceral fat. Visceral is the intra-abdominal fat, which is the metabolically active fat, which is the fat which causes all the problems, which is the one which leads to fatty acid accumulation in the liver, leading to non-alcoholic fatty liver disease and everything, and which is the cause for insulin resistance. So this is a very beneficial fat distribution with pioglitazone. So though there is a weight gain, it is a cosmetic weight gain, not a pathological weight gain. So weight gain, your SGLT2 and GLP-1 will cause weight loss, sorry. Metformin and DPP-4 inhibitors are weight neutral. Will cause weight gain, but it is a beneficial weight gain. Now let us look at the renoprotective benefit. Your DPP-4 inhibitor, linagliptin, has been shown to have reduction in albumin creatinine ratio and reduction in proteinuria. And probably this is because of inhibition of podocyte damage, inhibition of myofibroblast transformation, and increase in the GLP-1 receptor expression in the kidney. But the most important and the best drugs for a good renal outcome are the SGLT2 inhibitors. And across the board, everyone, whether it is Empagliflozin, Cana or DAPA, it has shown very good results in renal endpoints across the board. So consistent and impressive renal benefits are observed in both primary and secondary prevention. It can prevent kidney damage. It can even reverse albuminuria and microalbuminuria, and it has got a lot of benefits in renal function. Even pioglitazone in studies, Quartet study and others have shown that it can reduce albuminuria. So when you talk of renoprotective action, SGLT2 top of the line, DPP4 okay, PIO okay. Now we come to the last, cardiovascular benefit. Like I had said earlier, 80% of our patients are going to die of a cardiovascular problem. So you have to have drugs which will be cardioprotective. The first drug to be proven cardioprotective was metformin, which was seen in the UKPDS study, especially in the subgroup of overweight patients, which was a small subgroup, about 350 patients. But it showed fantastic improvement, 32% relative risk in diabetes-related endpoint, death, mortality, and myocardial infarction. Super reports. And based on this, the United States FDA approved metformin for use in the US. It was not earlier approved in the US. Studies of pioglitazone indicating the anti-erythrogenic and cardioprotective effects. 4 randomized controlled trials, Proactive, Chicago, Periscope, IRIS. IRIS we discussed. Several meta-analyses and 3 large observational studies from UK. Now the Proactive study, this was a study which used pioglitazone in patients who already had a myocardial infarction. And there they shown a recurrent fatal, non-fatal MI reduction of 28%, acute coronary syndrome 37%, secondary stroke by 47%. Because of this study, which showed that stroke reduction was 47%, that is why the IRIS study was done. Though there was an increase in incidence of heart failure in these patients, it has been shown that pioglitazone can aggravate the chance of heart failure in somebody who has a low ejection fraction. But there was no increased mortality. And what they have shown in the meta-analysis is those patients, even though they had a heart failure because of pioglitazone, they have lived longer. IRIS study I've already discussed. This is again to show that treating insulin resistance had a beneficial effect even in pre-diabetic patients. This was a comment in Diabetic Med by Ralph DiFranzo, who was the father of that ominous octet, and Robert Ryder about pioglitazone. What do they say? Inexpensive. Now, why does an American say it is inexpensive? Because it has gone off patent, so it has become cheap. Otherwise, it was very expensive. So it is inexpensive, very effective in reducing HbA1c, no evidence of bladder cancer, plenty of evidence of cardiovascular benefit. So that is in one short sentence what a pioglitazone is. Then you have the SGLT2 inhibitors. That is your empagliflozin, dapagliflozin, canagliflozin. Superb results seen with all of them actually. And in fact, the benefit starts much earlier. By 6 months, you see the reduction in mortality. And you have a 38% reduction in cardiovascular death. So when you look at a meta-analysis of all the SGLT2 inhibitors, what do you find? It reduces atherosclerotic events in secondary prevention, but not in primary prevention. Means it doesn't prevent myocardial infarction, but it reduces all-cause mortality. For heart failure and CV risk, absolutely no problem in both primary and secondary prevention. Wonderful results with an SGLT2 inhibitor. In fact, yesterday I was on a Zoom meeting with eminent cardiologist also on the panel. And now the cardiologists are using SGLT2 in patients who don't have diabetes because of the beneficial effects seen in terms of heart failure. And in fact, Dr. Ponde was there with me on the thing. He has a series of 87 patients, non-diabetics, where he has been giving them SGLT2 as an add-on to help in their heart failure situation. So when you look at overall combined benefit of cardiovascular mortality, non-fatal myocardial infarction and stroke, pioglitazone comes right on top. These are all the DPP4 and the GLP-1. No change, no benefit, not statistically significant. Then empagliflozin comes in, all the SGLT2 come in, and you have liraglutide and semaglutide GLP-1 analog, which has good results. So when you talk of CV benefits, metformin, PIO, SGLT2, GLP-1, and in GLP-1 mainly liraglutide and semaglutide. Number of medications usually taken increases with duration of diabetes. And now, as of January last year, the US FDA has okayed a triple drug combination pill, which is an extended release metformin, linagliptin, and an empagliflozin. Wonderful. I would add a pioglitazone to this and it would make a fantastic combination. So, what is the pathophysiological cocktail that you are looking at to treat your type 2 diabetic? If you see, you don't want weight gain, you don't want hypoglycemia, and you want all the benefits: renal, cardiovascular, beta cell, insulin resistance. So, metformin and pio. In the Indian population, I think every type 2 diabetic should get a metformin and pio unless there is a contraindication. A gliptin, that is a DPP-4 inhibitor, and a SGLT2, that is another pill combination, and that would be a deadly combination. The other would be metformin plus a gliptin and SGLT2, and a metformin, pio, and a SGLT2. I have been using this combination a lot of late because see, pio causes fluid retention and weight gain. SGLT2 will reduce the weight and remove the fluid. So this becomes a beautiful combination for long-term use. So what should be the strategy? The macrovascular damage, I mean your coronary artery disease, cerebrovascular disease, peripheral vascular disease starts many years before the onset of diabetes. It is not dependent on hyperglycemia. So insulin resistance and its complication and beta cell preservation have to be adequately addressed for positive long-term outcomes. If insulin resistance is treated right from day one, the day you see a patient, I am sure we will see lesser and lesser macrovascular and microvascular complications. Metformin plus pio is the most durable, less weight gain with metformin in place there. But if you add an SGLT2 to a metformin and pio, that's an unbeatable combination. No hypoglycemia, no weight gain, beautiful for macrovascular disease and microvascular disease and renal protection and cardio protection. That would be the ideal combination for every type 2 diabetic. Metformin and pio gives you best results when endogenous insulin is present. So what does it mean? Start as early as possible, not after 10 years of his diabetes. Right from day one, you put him on metformin, pio, and if required, add an SGLT2. So metformin plus pio for SGLT2 with endogenous insulin, early use is an intelligent use. So what should be the ideal algorithm? Evidence-based algorithm. You want to reduce peripheral insulin resistance, which should be done. Every Indian is insulin resistant. You want to preserve the beta cell so that you have a very durable glycemic control. And you don't want hypoglycemia. All these molecules will address that. Glitazone plus metformin, to my mind, every Indian should get it unless there is a contraindication. Every Indian type 2 diabetic, DPP-4 inhibitors and GLP-1 analogs and SGLT2 inhibitors. The GLP-1 analogs are very expensive. On an average, if you use a liraglutide 1.8 milligrams daily for a year, it will cost the patient about 1.5 lakh rupees per year, which most of our patients will not be able to afford, besides it is injectable. So if you can't control with this, then your next step would be to add a sulfonylurea. Glibenclamide, glipizide, glimepiride, glyclazide. Nowadays, nobody uses glibenclamide and glipizide because they have been shown to be not very cardio-friendly. Between glimepiride and glyclazide, to my mind, glyclazide is the best molecule as shown in advanced study. It is more cardio-friendly than glimepiride. It is more renal-friendly because it is not excreted by the kidney, so can be used even in renal failure. So these two drugs would be used. You have non-sulfonylurea, natticlonide, repaglinide, which can be used. If after this, you only have a postprandial hyperglycemia, not fasting, then you could use any of the alpha glucosidase inhibitors, acarbose, voglibose, or miglitol. And if with all this, your patient's sugars are still not controlled, then you need to add on insulin. This would be the ideal algorithm in the management of type 2 diabetes. Thank you very much, ladies and gentlemen. I would be only too happy to take questions.
Thank you, Vijay, for a wonderful discussion, which even a non-academic surgeon like me knows.